Hello, everyone. It's a pleasure to meet all of you. And this presentation is primarily on behalf of the Vaccine Impact Modeling Consortium, and a number of them are here. So any one of us could be presenting this just with luck of the draw that I'm presenting today. So you're welcome to engage with all of us like in different forms and kind of just give a background of the history of the consortium so far and what are the current plans moving forward as well. And it'll be driven by many of your interests as well. And yeah, sorry. Okay. Okay. Okay, yeah. So it's a consortium of modelers and who are working with stakeholders as well, and primarily generating estimates for vaccination impact. In the last 5 years, it has been for 12 different antigens, and then moving for about 10 different antigens as well. And primarily, these estimates has been used by both Gavi and as well as by other stakeholders, including WHO, as by informing other the Immunization Agenda 2030 and so on and so forth. But also all these estimates are publicly accessible for all these countries. So we're looking forward to engaging with national stakeholders as well to use this and also to inform us some of these estimates may not be meaningful as well so that we can revise these estimates and make it better and useful as well. Yeah. The consortium was originally formed in 2016 and kind of became much more operational in like 2017, 2018, and so forth. And estimates are generated every 2 years for different strategic scenarios that are actually defined by the different stakeholders, especially from Gavi, from WHO, Gates Foundation as well, but also something that's much more as pragmatic as possible. And and the after the first 5 year cycle was completed, it has been renewed for the next 5 years as well. And along with one of the things that has been working on for the next 5 years moving forward is it's going to be much more nimble and responsive to the actual needs of any policy relevant questions that you may be able to pose as well. So that is the kind of the format moving forward as well. So in addition to generating estimates for some of those strategic vaccination scenarios, project specific working groups will be put together as needed. And doesn't always have to involve the current folks involved in the consortium. It will also be open for other folks who can contribute as well, and then put together, answer those questions, and then it'll be disbanded and then moving to the next project working groups and so forth. And I'll kind of showcase one of those examples as well. And this is one of the first consortium-wide publication that looked into the impact of vaccines from 2000 to 2030, and looking across these 10 different antigens and kind of highlighting the retrospective impact of the vaccination that has been done up from 2000 to 2019, but also making projections moving forward from 2020 to 2030 as well. And it's disaggregated by different antigens and as well as across each of those countries as well. And moving forward, again, the vision is going to be like to provide these estimates as reliable as possible, but also to keep improving on a continual basis. And also basically working with stakeholders, engaging on policy relevant questions and being responsive and nimble to answer questions as they come in from different stakeholders as well. And one of the key changes that has been happening is also to provide like training programs as well, which was quite limited in the first version. But these training programs will be much more available for both modelers as well as policymakers moving along as well, so that you'll be much more informed users of these model-based estimates, but also being much more informed asking questions that could be answered by these models as well. And currently, the consortium is focused on these 10 different antigens, and that includes basically like looking from cholera to COVID-19, hepatitis B, HPV, measles, meningococcal vaccines, rubella, typhoid, yellow fever as well. But also we have estimates generated for other 4 different vaccines as well, which is pneumococcal, Hib vaccine, rotavirus, and as well as Japanese encephalitis as well. So those estimates can be pulled in as well. And also there are additional estimates for diphtheria, tetanus, and pertussis as well, so you can put together. So pretty much it's quite comprehensive to actually evaluate all the vaccines that are delivered by the regular EPI system in around like 117 low and middle income countries now. And with respect to, as again, like kind of put together like the questions, and it's going to be like, it's kind of a coordinated and also stakeholder engagement, and also trying to build a kind of an ecosystem building and a kind of a shared learning agenda that's kind of useful for all our community of practice as well. And one additional change coming over to this version, the next phase, is also looking at the impact of climate change as well. And the initial focus is primarily looking at the impact of, especially with respect to differences in risk, especially for vector-borne diseases as well, especially for malaria and as well as for yellow fever as well. But it could be expanded for other diseases which could be impacted by growing risk of climate change, including for cholera and typhoid as well. So that's one of the areas that's being added on this one. And this, for this particular part of the program, the funding is coming from Wellcome Trust, and for the regular program, it is continued funding from Garvey and Gates Foundation as well. And the kind of format looking for the project working groups, basically, these are policy relevant questions that are posed to VIMC, and if VIMC has the capacity to take it on, or at least appropriate to take it on, then a project working group is set, and it include folks from internal but also external as well of the consortium. And by working with them basically to refine the questions and then to agree on the model and the key input assumptions, and then working together and then actually disseminating results as well. So it's a kind of a schematic of what we envision how moving forward is with different working groups, the stakeholders, and then also the modelers, which could be both part of the current VMC as well as other folks outside of VMC as well, and then answering these questions. And on the left side, what you see is a kind of a flow chart of the different decision-making points on how this working group works. But I kind of showcase with one example. So this was a kind of a request that was put together by WHO CRO around the end of 2022, basically looking at different elimination scenarios for measles and rubella. And once the group was basically convened and VIMC was responsive to this particular one, a working group was actually put together, and there's a continuous engagement between the stakeholders and the modelers. And then through this continued working groups like meetings and so forth, around like by end of January, the vaccination scenarios were actually streamlined of what they think is of strategic importance to the stakeholders. And then once these estimates were generated, and then these estimates were presented in Delhi with the stakeholders, and then they were used. And this was primarily led by the stakeholders in WHO, and VMC was primarily providing the support estimates to those scenarios that they actually requested for. So this is one example. This was done in a streamlined manner within 4 months. But moving forward, it's not a 4 month, it's not a timeline defined per se. It may define based on the project needs and so forth, but it's quite simple, flexible, but there's resources available as any from national, subnational, regional, global, whichever level it might be. And this is an example of a project we were looking at. This was led by the Ministry of Health in Kenya, both the cancer division program in working with an immunization program in Kenya. Here specifically looking at the impact of HPV vaccination. And one of the things that we wanted to look at, basically look at the impact of the Sessolin and Cervarus vaccine, in addition to Gardasil 4 and Gardasil 9 as well. So looking at the health impact estimates, 3 of those vaccines turned out to be quite cost effective, but not Gardasil 9. But when you start looking at the societal impact as well, Gardasil 9 turns out to be at the borderline as well. But again, it's kind of driven by the stakeholders, they did the analysis, and it's informing the NITAC discussions currently ongoing in Kenya as well. And this is like kind of some of the studies that are conducted to look at the impact of disruption in immunization services during the COVID-19 pandemic as well. And some of those things, both looking at the routine immunization impact as well with respect to suspension of campaigns that happened for a period of months during 2020 as well. What are the long-term impacts moving forward as well? And also for resumption of campaigns as well, like how to prioritize those campaigns between measles, yellow fever, and also looking at basically at meningococcal, which campaigns to actually start off between those different campaigns. And there were additional studies also conducted as well. Basically, some of the studies by Allison actually looking into the additional costing that was required, because some of the recommendations of these studies are basically if you can implement routine vaccination campaign in a safe manner or in a COVID safe manner, it actually turned out to be highly beneficial, cost beneficial to do it. But there are additional costs, both on human resources as well as on supplies that were needed, and that need to be taken into account as well. And how do you actually derive those financial resources? And also Brian did additional studies basically looking at the benefit cost estimates as well. And these estimates tend to be the return on investment were highly beneficial. But one of the limiting factors is that how do you actually mobilize those additional, both on human resources as well as on supplies, so that you these services can be continued in a safe and effective manner. So these are some of the things that are put together. But one of the things that was done together is like some of these models and estimates were actually put together in a much more user-friendly tool that was actually jointly put together by WHO, UNICEF, and UNFPA, which was like kind of a spreadsheet-based decision support tool that was actually sent to all the at the country level, wherein they can run their models by themselves and make their own benefit cost ratios on how and make their own decision making points. So that was one of the things that is beyond just the estimates. It could be actually be customized and modified and adaptable at the country level decision making. And beyond gender estimates, also some of these things we do develop like new methods as well. So in addition to basically generating estimates by birth cohort, what is the impact of vaccination across the life course, as well as by calendar year for the children who are, or the whole population who have received vaccines anytime in the life course, what is the impact on a particular calendar year, so forth. But also from a programmatic perspective, this was actually driven by stakeholders as well. One of the key questions they wanted is, what is the impact of the vaccines delivered in this year or the next year? So that is being generated by generating those vaccine impact ratios. And once these impact ratios are generated by antigen, by year, by each country, even if the actual coverage changes, we can actually generate estimates quite quickly, rapidly, saying what will be the impact of these vaccines delivered in this year over the life course. And just to kind of summarize, like this is just, I'm kind of showing a few examples of work. It's a kind of a large consortium of models that are involved, and they're very open for collaborations. And as I kind of showcase one of those examples of working groups and so forth, this is going to be much more stakeholder driven based on your needs, and PIMC is very happy to collaborate with you. And the ones on the left are the estimates in the pre-COVID era, this thing, and the right one is also looking at the impact where, because of the COVID-related disruptions, how we can basically get back to the baseline before, what is the recovery scenarios as well. And that's taking that one to the third publication as well. And all of these estimates are publicly accessible. You are welcome to use it. And if some of them are not meaningful, please let us know. And to contact the consortium, all the contact folks are available on the page as well. And Carolyn is our director, Katie is our research lead, and Kim is our project manager, and Diana is a project coordinator. We'll be very happy to respond to you, especially Kim and Diana will get back to you almost within 24 hours, I would say. Okay, thank you very much. Yeah.
Great, thank you very much. We would like now to invite Uni Sim to take the stage. She will be talking about using the Immunization Agenda 2030 impact and cost estimate for future decisions. A warm welcome for Uni.
Thank you. Good afternoon, everyone. Good afternoon, everyone. My name is Uni Sim from WHO's Immunization Department, and more precisely, Value of Vaccine Economics and Modeling team. And first of all, thank you very much for all the insightful presentation and discussion. And then it was a really good opportunity for me to learn and more from your experiences. So for this last session of the Pre-Congress, my focus of my talk is to discuss and share with you our experience of generating and using cost and impact estimates for the Immunization Agenda 2030. So all the brief recap of the IHEA 2030 and analytical framework and results, and most importantly, some use cases and lessons learned from this experience. So as you all may know, the IHEA 2030 is an ambitious global strategy that aims to maximize the impact of vaccination. It looks at the 10-year time frame from 2021 to 2030, and it was endorsed by the World Health Assembly with the support from all 194 WHO member states and all partners involved. So this is a really ambitious vision that to see the world with everyone, everywhere, and every age fully benefits from vaccine to improve their health and well-being, which translates into these impact goals that stimulate the action for the health security, access to vaccines and innovation, as well as universal health coverage. And this updates the previous strategy, the Global Vaccination Action Plan, and then this is built based on the lessons learned from the previous strategy, as well as lessons learned from this exceptional period, the COVID-19 pandemic. IHEA 2030 is grounded in 7 strategic priorities and 4 core principles for actions in this slide. And there is a big lesson learned from the previous decade about some disconnection between the global and country level strategies. So IHEA 2030 really focuses on the co-creation with the involvement of countries. And also it is flexibly designed so that it could be adapted to the local context and revised throughout the decade, and especially given the COVID-19 pandemic. So there's flexibility needed to revise the strategy. So country, that's their own targets and milestones and strategies in line with global level IHEA 2030 strategy, Gavi strategy, and other regional level frameworks. And for successful implementation of this strategy, so there are 4 operating elements. The first is the regional and country level strategies for operational planning. And second, the monitoring and evaluation framework to track the annual progress. Third is the appropriate mechanism for ownership and accountability, and communication and advocacy element for appropriate messaging to stimulate action from all stakeholders. So during this design phase, we are asked these 2 questions. So what is the impact of vaccination on mortality for this decade at the global level? And second, how much investment is needed to achieve the IHEA 2030 targets? So this is a question that our team received. And I would like to add that, okay, the third question will be, how do we achieve this within a short time frame? We have to do this within an 8 month. So we embark on the journey of generating these estimates based on this time frame of the next decade, future projection for all member states, and 14 pathogens identified based on data availability given the short time frame. And these are the 3 outputs that we are aiming for, and which I would like to walk you through in the next slides. Yes, so there are 3 groups that we identify. So first, these 10 pathogens on the slide, so which was already covered by the Vaccine Impact Modeling Consortium, for which Kaza gave a really great presentation. So we directly source these estimates. But for these, for some of the, so the IMC targets only subset of these member states. So for the group number 2, we extrapolate the existing estimates to the remaining member states using the socio-demographic index or healthcare access and quality index as a covariates for our relative risk model. So for the third group, the 4 pathogens, diphtheria, tetanus, pertussis, and tuberculosis for BCG vaccine, we utilize the global burden of disease estimates as well as existing coverage estimate and effectiveness results from the published studies. So I won't go into more details. You may be really interested in technical details, but I'll share this link so that you can actually learn more from this preprint. So first is, so on the left, this is a coverage scenario for IHEA 2030 based on expert consultation, which shows the end targets for 2030 and vaccine introduction and scale up scenario for each pathogen in each country. And the end result is on your right. So it's 4.4. So this is the number of the future lives deaths averted through vaccination from 2021 to 2030 for all member states, compared to the no vaccination as a counterfactual. And the lifetime impact is aggregated for the years when the vaccines are delivered, according to the methodology that Kaza also previously shared. So the result shows that 4.4 million in 2021 to 4.8, rising up to the 4.8 million, and then resulting in the 50 million, around 50 million as an aggregate estimate for the next decade. And as a companion piece, the second question, so we also estimated the resource requirement to reach these coverage targets. So the IEA 2030 coverage scenarios serve as a basis for calculating the number of doses, and the other elements you see on the slide, like vaccine price, vaccine cost, and delivery cost, has actually been extensively sourced from the community of practice, which really appreciated that. And especially for the delivery costing, empirical costing, and modeled estimates, as well as the national administrative data. We triangulate those based on the availability and use a regression model as needed. And just to key highlights from the result so total cost of immunization program totaling up to 270 billion, and the incremental cost is that 90? Sorry, 90 billion. And so the difference between the total and incremental cost is, for incremental cost, we keep the 2020 coverage constant throughout the decade. So this signifies that we only gonna look at the differential in the immunization coverage, and then assess the resource requirement separately from what is total as needed to reach the targets, including all the system cost and cost element that I showed in the previous slide. And based on the introduction scenario, that the PCB, it has the highest incremental cost. And if you see the percentage difference, is 60% more compared to the 2020, and followed by HPV. And the average cost per child based on immunizations and schedule, excluding polio, is 190 per child, and 61 per child when on average. And for more information, you'll see the link here, and also we have Celine and Brian from WHO, the Johns Hopkins IVAC team sitting there. So please reach out to us after the session for more detailed questions. So use cases. So what are the use cases of these impact and cost estimates? First, advocacy. So you may have seen this 50 million lives saved number in any press release and advocacy materials during the World Immunization Week in 2021. This is when we release the estimates. And also, this is the time when the framework for action for IEA 2030 was endorsed by the 24th World Health Assembly. And the second use case is monitoring evaluation. It was used as an impact goal indicator 1.1, number of future death averted through immunization. So when it is one of the 7 impact goal indicators used for IEA 2030 monitoring and evaluation framework. And then when you go on a website for the scorecard, you can annually track the progress based on rerunning the model for updated unit coverage and demographic estimates against the target that was originally set in 2021. So that is the second use case. And third is, it was also used as an input into the WHO's second investment case, which took a look at the benefits from all the health intervention and health activity areas that WHO were involved, and WHO's attributed impact on this, the total global benefits compared to the WHO's expected budget, and $1 investment resulting in $35 of the benefits. And this work was led by the Victoria University and Kim. Yeah, please reach out to Kim and for more questions and information if you're interested in this specific work. Yeah, just to share some lessons learned from this experience. First is the community of practice who was really critical in identifying our partners as well as latest available evidence that I explained briefly during the delivery costing section. and early engagement and consultation with partners to coordinate this global estimates generation. BIMC was a very integral part of this project from the beginning, and also Dr. Katie Gaythorpe, who's the science lead, served on our project team. And we also set up a stakeholder committee inviting all relevant global stakeholders who have experience generating this estimates, especially Gavi, to align with their strategy and also learn from their previous experiences of generating similar global level estimates, and also the need to, for example, lock the model until 2025 to facilitate the communication of this annual tracking process to the external audience. And third is iterative development of impact goal indicator 1.1 within this operation structure of the IHEA 2030. So we work closely with the IHEA 2030 monitoring and evaluation group and advocacy and communication group early on, and provide and receive the feedback, especially on this indicator. And next is independent appraisal of modeled evidence by the Immunization and Vaccine-Related Implementation Research Advisory Committee. So just to go to the next slide briefly, this is the independent advisory group to WHO providing appraisal and advice on implementation research, and then comprising 15 members from the various disciplines, including health economics. So it usually served as a body who provided appraisals that inform directly the policy recommendations provided by the strategic advisory group of experts on immunization called SAGE. And we had a standing session for IHEA 2030 impact and cost estimates since 2020. So, and also this proved particularly helpful during this exceptional period of delayed peer review in the scientific community, and also of the strategic importance of this work to the global strategies and policies. And just to give you a quick update on, so currently there's ongoing work on developing guidance for how to best translate modeled evidence into informed immunization strategies and policies and programs. And we have a secretary from IVERAC, Philip Lamba, sitting in this room. So if you have any questions, also let's meet at the cocktail session. Go back to lessons learned. So finally, we had a chance to leverage this IHEA 2030 mechanism to receive feedback from member states, especially regional offices, due to our intended audience group, global and regional level stakeholders, to get more feedback on how this indicator and estimates could be used for their purpose. And maybe the next lesson is very critical, the acknowledgement of the limitations inherent in this global level crude estimates. So we sometimes get as requests from whether this could be used for specific country at the specific purpose at the country level. So in such case, we consult with our stakeholders and internally to see whether to appropriately adjust the targeting of the use cases and determine whether this is fit for purpose. And most importantly, these lessons to be iterated and used as an input into the next iteration of our estimates. So by 2025, we aim to update this target with expanded scope of pathogens and impact measures, not only the mortality impact, but morbidity by adding DALI, and also include other vaccination activities beyond routine immunization. Finally, just to reflect the principle of the IHEA 2030, this is not a solo effort by WHO, but all parties involved and everyone who provided input and their guidance. So we like to acknowledge everyone who has been involved in these collaborative efforts. Thanks. I'll stop here.
Thank you. Thank you, Uni. I would like now to invite Todi Mendisu for her presentation about using health and economic impact evidence at Gavi to inform investment decisions and resource mobilization. Thank you.
Good afternoon, everybody. I'm Todi Mengistu. I am a senior program officer at the measurement and evaluation and learning team at Gavi. And I'll be talking to you a little bit about how we use health and economic data for resource mobilization and also strategic investments at Gavi, mostly at the portfolio level. So I'll start with just giving you a little bit of an overview of Gavi. I know most people know it, but just for completeness. And then I'll go into a little bit the routine uses of these types of data at Gavi, and then go into the core of it with how we've used it for resource mobilization, as well as for investment decisions. And then I'll finish by highlighting what we're currently working on, and also, since I have the community of practice, putting in a plug as to all the evidence needs that we need going forward. So just to start, what is Gavi? Gavi is an alliance of public and private partners, and the aim is really to increase equitable access to new vaccines. So as part of that, we've supported since inception in 2000, about 78 low and middle income countries to increase vaccine uptake, and also supported health systems in order to deliver those vaccines. If you count COVID vaccination over the last 3 years, that increases to about 140 countries. The portfolio of vaccines itself has really grown over time. And as currently we're supporting vaccines against 19 infectious diseases. So that's quite a big scale up over since inception over time. And it's between 50 different products. So Gavi at the portfolio level has a very strong culture of using health and economic data for a variety of reasons. The first is really for routine monitoring, and I won't go into that. It's very similar to what the IHEA 2030 has done. It's essentially setting targets as well as monitoring them year on year to make sure that we're meeting them. And then we also do a lot of advocacy messaging. And what I'll be talking about, resource mobilization, and also vaccine investment decisions. So I'll give you an example of how we used it for resource mobilization. This is just one of a number of things that we've done, but just to give you a comprehensive example. For the last investment case for Gavi, so Gavi has a 5-year cycle. So for each cycle, we raise resources. What we did is basically write the investment opportunity for donors. And basically what that document does is outline Gavi's vision. So there were about 5 commitments that were made to donors, and 2 of those were really based on health impact as well as economic impact. The health impacts were 7 to 8 million deaths averted over the next 5 years. And with that, and this was 80 to 100 billion economic benefits generated to, that would be generated if the ask was fulfilled. So as part of that, we also outlined the expenditures that we expect to have. So that table over there gives you all the expenditures that we anticipate given the ask, and what the deaths averted are for each of those vaccines. Internally, we also created a tool for our donor managers to facilitate communication with donors when they're thinking about investing in Gavi. So something like, okay, if you give X amount of dollars, you'd get this amount of benefits, basically, both in terms of deaths averted as well as economic benefits. So how did we arrive at these numbers, these high-level commitments? So a lot of it is based on vaccine by vaccine, year-on-year forecasts of Gavi's vaccine programming. And basically what we did was looked at Gavi's strategy, translated that into a forecast, and then looked at the associated coverage with those expenditures, basically. So those coverages were then taken by the VIMC to generate the deaths averted related to those. And then the Johns Hopkins group, the VERSE group, translated those into economic benefits. So they're all interlinked and they're all based on data that is reliable and transparently produced. As part of the investment opportunity, we also had a technical appendix where we outlined all of our methods, and it's all in that link over there. As part of the investment opportunity, we also did a fair bit of other analytics, more around advocacy. There was a piece on, for example, financial risk protection. So that we looked at the Gavi supported financial risk protection, for example. So those are many other pieces, and it's all in the technical appendix for if you are interested. So in terms of how we use the health and economic data for decisions, especially around vaccine investments, we have every 5 years, there's a cycle for vaccine investment strategies. This is where Gavi decides on which vaccines we'll be supporting in the next strategic period. And so that's based on a transparent process that involves all relevant stakeholders. And it requires that we define a framework to assess each of those vaccines that are being put to evaluation. So as part of that, there's an analytical framework that's developed, and I'll go more into that in a little bit. But the idea there is once we go through that process, we get to a short list. So there's a long list of vaccines. We get to a short list based on that assessment. And then from that short list, you get to an investment case. And what can come out of that investment case is either we will be supporting the vaccine, or we will be as a routine program, or as a stockpile program, or we would also be funding a learning agenda if we find that the evidence was not sufficient. So these are the evaluation framework. We are currently undergoing one vaccine investment strategy right now. So these are the evaluation frameworks that we're looking at. There are 2 of them. So the first one is looking at the endemic framework. So these are for vaccines that would be supported through routine or campaign. And the second one is for the epidemic frameworks. And those things look at different aspects of each of the vaccines. I'll go into the endemic framework because that's the one that uses the health and impact data more extensively. And it has, as you can see, ranking criteria, key ranking criteria, the first one being health impact, deaths and DALYs averted. And then there's a value for money aspect, which looks at the cost of procurement with the deaths averted data, which is the cost per deaths averted, cost per DALYs averted. So each of those has a different weight. That weight is determined by the Gavi board, and then these are ranked. There's also other criteria that are called modulating criteria, which may or may not have data associated with them, and they basically would also be part of that decision space. So this is just like, we are currently undergoing the VIS 2024, like I said, but this is just to give you an example of what the analysis looks like for the VIS 2028 for one of the vaccines, which was Hep B birth dose. So each of the different vaccines that were being assessed at the time, they're compared with each other, both from the deaths averted and the the value for money aspects. The birth dose is one of those that was actually is going to be supported starting in 2026. Okay, so now shifting a little bit in terms of what are we currently working on. So currently, like I said, we have a 5-year cycle. So we are currently in the 5.0 cycle. So the focus in this cycle has been around the equity agenda, as well as which essentially is the zero dose agenda. And we're also starting to think about the new strategy in 6.0, because for the new strategy, we need to start thinking about the investment case, which would be released sometime next year. So for that, we need to understand what our strategy will be. So, where do we go from the equity agenda? We also have an expanding list of vaccines, and they're not all given at the EPI stage. They're all throughout the life cycle, the life course. And then finally, we also have the outbreak response, which has taken quite a larger share of Gavi resources. So in terms of evidence needs, we really need to understand a lot of the costs of these programs. I think health system strengthening was mentioned a few times. The equity agenda, as Ula mentioned earlier, is really about strengthening health systems, but we don't really have a good way of evaluating it. So we don't really know how to put all of that in the same thing and decide, okay, how do we go about making trade-offs? Because at some point for our strategy, we need to decide where we're going to put resources and what we're going to decide to go with. So that's a key one, and that requires cost and effectiveness data. So that's a big area that we're looking into. The outbreak response is another one. We do have a good framework for the preventive pieces of vaccination, but the outbreak response, we don't really have a good counterfactual. And also, how do you evaluate things like, if you have an epidemic and you have things like the GDP effects, we don't really have a good framework for assessing those. So that's something that we're thinking about. So thanks very much.
Thank you. Thank you, Todi. And now we would like to welcome Raymond Hutubesi for a presentation about learnings from the G20 Joint Finance and Health Task Force for Pandemic Preparedness.
Okay, thank you for giving me the floor, and also to share the experience. So I was invited also to share my experience as the coordinator for the Secretariat of the Joint Finance Health Task Force for Pandemic Prevention, Preparedness and Response. And so I'm working for WHO, but I have been on loan for the last 20 months to the Secretariat. So what I would like to do with you is, and I think we're going, listening to the presentations from Gavi, but also UNI presented IHEA 2030 and the VIMC. I think it's going maybe a level higher at the global level, but I think what is being discussed at this level is important, I think, for health and economics in general, but it might also have repercussions for, but more consequences for the need of evidence, and not, as I have said in our previous sessions, for ministries of health, but also for ministries of finance and even for central bank governors who are looking actually for information being presented at this Health Economics Congress, but also definitely also for vaccines as part, as David said, of primary healthcare. Where do we need to invest when the next pandemic will hit us? And so, I think it's a good idea that I familiarize you a bit what at that level is being discussed, and hopefully, well, let me show you what I was planning to do. I have a couple of slides on, for those who are not familiar, how the G20 works, and also what the Joint Finance Health Task Force is doing and how it originated. And and then I give you a little bit of background to compare the seriousness of this pandemic we just had behind us compared to the financial crisis in 2009. And then in some lessons learned in terms of the coordination between finance and health ministers domestically, but also internationally, how to better coordinate this. In particular, what Tori just presented on investment strategies, or what Uni presented, but maybe at a higher level to save lives and livelihoods, but then also a little bit more on financing. So financing of health systems but also beyond the health sector, and trying to link this back to many of the themes we have discussed within this community of practice. So let me just quickly start on the background of the G20. It's a group of 20 countries, major economies and emerging markets. It's a premier forum for international and economic cooperation. It plays an important role in shaping the strengthening global architecture and governance on a major of international economic issues. So they're discussing in this task force in particular the pandemic, but also looking at cyber crime internationally, climate change. So this is one of those kind of working groups where they discuss. And so here I put the members, the members of the G20, and then every year the presidency. So this year the presidency of the G20 is under India. They have invited the countries on the right hand side to be guest countries at the table and to discuss these issues. So so why was this Joint Finance Health Task Force established? So it was actually proposed under the Italian presidency in 2021, really to further strengthening the crucial coordination between finance and health ministries, but also internationally, globally. And the G20 members agreed that there should be a task force to better coordinate health and finance in terms to protect, the economic, the global stability, and also, avoid these shocks to financial markets. And so with this collaboration and global cooperation on these issues relating to pandemic prevention, preparedness and response, they hope that we will be better prepared when the next pandemic will hit us. And it was actually established as a history in 2021, but actually it went already back before the pandemic, when under the G20 presidency of Japan, they already discussed universal health coverage. So again, Ministry of Finance were also thinking about, really about universal health coverage. And then it was picked up by Saudi Arabia in 2020, looking at post-COVID pandemic and health global economic recovery. But then also, as I said earlier, under the Italian presidency, to establish the task force. And then last year, when the G20 was under the presidency of Indonesia, they then established the secretariat and also established the initial roadmap. You might also have heard that they have also established a pandemic fund that is now with the World Bank, but is also technically supported by the emergency department of the WHO. And they came up with the Bali Declaration last year. And so the mandate of the task force, of which I'm the coordinator of, and the secretariat is hosted at the WHO under the Director General of the WHO. In that, the G20 health ministers and finance ministers have agreed on these areas of work. So really to better understand the economic vulnerabilities, the economic vulnerabilities and the risks from pandemics, but also how to mitigate these risks. But also share best practices. What does work in terms of coordination between finance and health? And also develop between ministries of finance and health joint responses to pandemic. And that it's not only for the next pandemic, but even during peacetime, over the coming years, they would like to discuss this further. How can we better prepare ourselves by having the right investments, for example, in health systems, in order to absorb, these shocks of future pandemics. And so to better to continue developing finance and health coordination arrangements, but what they also have agreed to include in the G20 the voice of low middle income countries through regional organizations. And there is now also a multi-year planning horizon within the work plan. So just to give you a background of the seriousness of the pandemic, here you see and I borrowed this slide from Ruchir Agrawal from the IMF to put things in perspectives. You know, if you and this to me is really based on these projections from the IMF. In 2009, the financial crisis led to this drop in economic world economic growth. But when you then look at the numbers for COVID-19, it went even to a negative growth. So just to show what the impact actually was on the global economy, and that really kind of was one of the reasons why they also established this task force. So. So the G20 post global financial crisis response focused on tackling system threats from the financial market. But also when you look at the COVID-19 crisis, it highlights that health threats also pose really huge systemic risks to the global economy, as I showed on you on the previous slide. So there are three differences compared to the financial crisis. It's health threats can be much more damaging, not only on the global economy, but also as lives, as we have witnessed, but also through less common in the past. But there is a huge uncertainties on about the frequency of future pandemics, and that health threats can originate almost everywhere. You know, it can easily spill over from one country to the other. So the implication is that expanding the scope of the risk to responses, that health threats should also be kind of better maybe understood, and that there should be a stronger case for international cooperation and sharing of best practices between finance and health. So I think this slide also kind of illustrates one of the priorities. So here you see a slide on GDP on the vertical axis and the trajectory of GDP over time. You see when the pandemic hits, then there will be a dip in economic growth and a dip in GDP, and it really depends of how countries are resilient and how also whether countries do have these systematic vulnerabilities and how can they respond to absorb the economic impact. And so therefore ministries of finance and health should increase these economic systemic resilience of their health and economic systems, but also how can they bounce back rapidly to increase their health systems, but also fiscal response capacity. And so that is in particular, and I'll show it to you in the next couple of slides what kind of evidence they are looking for. Not only in understanding the vulnerabilities and the risks, but also the combination of preparedness in the future, not only for prevention and preparedness. As I said earlier, the pandemic fund was established, but also with regards to financing in terms of response financing, that there should be better understanding and enhanced preparedness to rapid surge financing from day zero. And we also identified during COVID, it's not only a matter of, there was insufficient preparedness for this surge financing. So also getting the funds released in countries as soon as the pandemic was announced. So let me finalize with a couple of slides in terms of where I think this community will kind of provide also the evidence and to the priorities of the task force. So in terms of the need for finance and health coordinations between Ministries of Finance and Health, I think it's really important to come up with these what we would call investments. You know, so health is not an investment; it's not a cost, but it's an investment. So, for example, investment cases will be needed in general for health interventions, but also, as we have discussed here, for vaccines and immunization programs. The other thing is what is important in the communication with the Ministry of Finance and Central Bank governance is that how health can contribute to macroeconomic stability and growth. So, for example, also to demonstrate the broader socio-economic impact of vaccines in combination with other interventions is an important issue to look at. And I think also during this, the last 2 days, many of these examples also have been demonstrated during the full value of vaccine assessments. I think this should be done across the board, not only for vaccines. So when it comes to the vulnerabilities and systemic risks, so investment strategies to save life, but also livelihoods, really to, and we had the discussion over the last couple of days. So during the COVID-19 pandemic, it's even with vaccines or the closure of economies, how to balance this. And one of the issues I think from this priority for the task force is looking at health systems resilience and the response capacity. And as was also discussed in the previous sessions, really strengthening health systems is part of it, but also better knowing the cost and finances needed for vaccine delivery. But also, as we have discussed, public health finance management is an important issue in order to disperse these funds in countries. The second issue here is macroeconomic stability. So not only looking at the mathematical models, looking at the epidemiological impact of vaccines or close downs and how many lives can be saved, but also what kind of consequences it has to other sectors of the economy. And tomorrow there will be another session on the integrated EPI macroeconomic models. Sorry, it was Wednesday. Yeah, Wednesday it is. Katrina sits in front of you, and so they will be part of that session. And if you want to know more about these integrated EPI macroeconomic models, I think I really invite you. And in the G20, the Ministers of Finance are really interested in these types of models to look at the kind of different mitigation and policy strategies that are run through these models to see not that the health interventions will save lives, but also will have an impact on the different sectors in the economy, expressed in GDP savings, but also, for example, in employment. And so several country studies will be presented in that session on Wednesday. I think it's from the Philippines, Argentina, South Africa. And so there have been some models have been run. Then also the social and economic protection. I think this is an important issue where also the task force is looking at, in particular also on the modeling interruptions of essential services during pandemics. I think there's also, we have been not being able to keep, for example, the immunization coverage up there was a kind of a dip after the announcement of the pandemic, and so how to also look at these issues. So let me my last slide, yes, is about this financing. So it's really important during pandemic. The time to action is very is important, and it is enormous during the pandemics. And so pre-arrangements of financings will be needed to be activated at day zero. So domestic search financing and investments for information, for R&D are needed. So again, going back to the discussions we had on the full value of vaccines at early stage, knowing what kind of investments are needed for new vaccines, but also, for example, doing more proactive investments in R&D for the next pathogen, the disease X. And there is a big project ongoing from CEPI also to look at the impact assessment of R&D. And then the last part is so not only looking at the gaps in financing for response, but also what we would call the functional gaps. Again, going back to better understand the country legislation and the rules around budgeting, public health finance management, etc., but also the speed for financing to get, for example, the vaccines to the citizens as fast as possible with with the funds available. So let me stop here and give it back to you.
Thank you. So yeah, I would like to invite back the presenters, Yuni, Todi, and Kaja, please. We're going to do just one round of questions for the presenters, and then the presenters have prepared some questions for the audience.
Thanks, y'all. Allison Portnoy, Boston University. So this isn't necessarily a question for you, Kaja. Just like want to take the opportunity of you talking about BIMC and some of the other things that have been said today and yesterday to maybe like send out yet another call to action for the funding agency stakeholders in the room. So there are some BIMC models that have the ability to answer economic questions, such as the HPV models that Kaja and I work on. And the project working groups that Kaja was talking about are only going to make, economic questions a priority if the stakeholders make those a priority. And so even though many of the modeling teams don't yet have that capacity, the expertise does exist, not only within the BIMC members who are sitting here in this room, but from several of the experts who are also here in this room. And so if we want to make that linkage, like Sarah was talking about yesterday, we're thinking about future pandemic preparedness and integrated economic epidemiological models, like can we actually maybe have the stakeholders who are involved in BIMC and the stakeholders who are involved in immunization economics talking to each other so we can try to build all of that capacity for the future and make those research questions a priority for both BIMC and immunization economics.
Oh, thanks. Very interesting sets of presentation. My question is to Todi. I was just wondering if you could please provide some more insights to Gavi's strategy for funding zero dose response. And, maybe for example, do you fund learning learnings to understand what the issues are, or do you actually fund interventions to address these bottlenecks in reaching zero-dose children? Thank you.
Thanks. Maybe one more question over there, Logan.
This is a question for Kaja. And maybe it links up a little with Allison's point about how VIMC has a capacity to develop, already has some, and can increase its capacity to include economic outcomes. And it links to earlier this morning's discussion about Gavi transition countries, right? So earlier, a recurring theme in the discussion about Gavi transition countries is there's a very limited fiscal space. And so it's a challenge to generate the kind of internal financing that you need to take over when Gavi support goes away. It seems that what would possibly help, I don't know if this is true, but it might be true, that evidence of the investment case of value for money to domestic budget holders of sustaining the financing of Gavi-financed vaccines could be helpful in generating that internal financing support. And it would seem that VIMC is ideally situated to provide the Gavi transition countries with that kind of investment case evidence. I was just wondering whether that is happening in any way.
And then my question, just to round it out, is for Raymond. I'm just wondering if the G20 has actually looked at the pain points related, or the task force has actually looked at the pain points related to financing of the COVID pandemic, because everyone was quick to pledge money or to commit it, slower to commit, very slow to disperse, and even slower to use. And actually we have billions of dollars, probably hundreds of millions of dollars just sitting at country level, tied up in various arrangements that cannot seem to move forward. So I'm just wondering, is there a list of the pain points that can be shared so that we can all learn from the past?
Thank you, Logan. I think we can go back to the panel.
Yeah, just to say, completely agree with you, Allison. I think this is the direction that we hope the VIMC is going to go, and also the stakeholders asking the questions. We hope the economic questions, we're certainly going to prioritize them, and other stakeholders, please do too. On the question about the Gavi strategy on zero dose, so the way Gavi has done it, there's been $500 million that has been that has been committed to zero dose in Gavi 5.0, and the countries, with help from partners, are supposed to come up with ways to reaching those zero dose children with that funding. Is the Equity Accelerator Fund. And there's been zero dose hubs. They're just being set up right now in select countries where there's learning that will be happening on how countries are trying to get to zero dose and what are the barriers to them. And there's I think it's $20 million project over, I think in 4 countries now: Uganda, Bangladesh, Nigeria, and I think Mali is the 4th country. And the idea is to have the learnings come up and summarize them for other countries to learn from them as well. So that's the current way we're doing this. And I think the VIMC question, do you want to take it? And yeah, so the VIMC, just to give you a little bit of background, in its first phase, in the first 2017 to 2021, was really set up to provide more of the global numbers for both Gavi, IE 2030 reporting. So it's really was focused on global modeling, and also, so that is the main premise. So the country piece hasn't been fleshed out that much, but the idea now is to move somewhat towards that direction. And some of the fellowships that Kaja was talking about is to try to get countries more involved and having country stakeholders be a bigger part of the VIMC going forward in the second phase, which runs up till 2027. Did you want to add anything?
Okay, let me perhaps respond to Logan's question. Yeah, definitely, Logan. These pain points, in particular on Act A and the slow disbursement of funds, is certainly a lesson learned, and to be and that also in the task force be discussing this, but also within the G20 Health Working Group. That's another working group within the G20. They are also tasks with learning the lessons from COVID-19 on the slow disbursement of funds into countries. And so the way they work is they have several meetings at deputy level over the year, and then what is then publicly available are during the summit. The presidency will come out with a final statement, and one of the paragraphs last year on Indonesia was also the lessons learned on financing, response financing during COVID, and hopefully in September the next declaration will come out with directions of how to better prepare the response financing and learn the lessons from COVID for next pandemics. But yes, the technical documents, unfortunately, they are not publicly available. They go really deep into many of these pain points. Yeah.
Great. I think we can now move to the questions that the presenters prepared for the audience. So the first question is, how could we use evidence in a more meaningful way at the country level? The second question is, what are the capacity needs at the country level to foster use of evidence for resource mobilization and decision-making? And the third question is, what kind of work are you conducting or planning to conduct that could be used to inform use cases shared by the presenters today? Anyone want to?
Hi, I'm Nicola Naylor from UK Health Security Agency, formerly Public Health England, and also LSHDM. Thank you so much for all of those really interesting presentations. So working at the UK HSA, which is a government body, but also doing some work with the WHO and hopefully potentially Gavi as well. I think, so to give a bit of context, we've done a project which is estimating the health economic burden of drug resistance, and how different vaccine scenarios can reduce the cost of antibiotic resistance at a regional level. So producing the estimates at WHO regional level and then potentially reworking them for Gavi regions as well. And now in my role with my UK HSA hat on, because all of the inputs were estimated at the country level and then aggregated up to the regional level, having those granular country level estimates readily available, so put up on a GitHub or shared in the appendices, having those country level inputs that were aggregated up is really useful, because then we can kind of pick and choose what we maybe have missing at a country level and say, okay, well, it's not maybe perfect, but these were the estimates that were used by Gavi or were used by the WHO. So when we're tailoring it to our country analysis, we can use that. So I think having as granular level sort of process inputs that feed into your models available for countries to use, and not just the end product is really useful.
Yeah, thank you so much. I love this as, I mean, it's late in the day, right? But I love this as the final session to kind of wrap up a few different threads that we've talked about over the 2 days. But I really appreciate, JP, what you're saying of like, wow, we have these estimates, and to get the global estimates, we actually are aggregating individual country estimates. So we do have the country estimates, and you could imagine that this same beautiful investment opportunity for Gavi, we could be making that for the investment opportunity for the Federal Ministry of Health in Nigeria. We could be making it for the FMOH in Ethiopia. I mean, for each of these countries, and each one, not only for transition, but at every point, we have the lives saved. We're pushing towards the DALIs, right? We have some estimate of the costs. And so I'm just wondering, can you comment a little bit more of like why we haven't done that yet? Is that a bandwidth issue? Is it a funding issue? Is it a lack of demand from countries? I think we've talked in this room about many different stakeholders are seeking to engage in advocacy with government and kind of making their own ready-made materials, but we actually have those numbers. We just haven't packaged them. And you could imagine that every Gavi country page has on it, download, here's my country-specific live save. Is it other things like sensitivity around the coverage projections? Like we don't want, even though it's there in published form, what assumptions we've made, we kind of don't want to say, actually, we assumed that you would introduce at this date and you'll achieve this coverage at this date. And we just don't want to put that in black and white? Or are we afraid of opening a can of worms? Like now everyone wants us to tailor the particular parameters or the particular input values, or they don't like the demographic data source we use and they want us to use national census or something. I mean, is it that kind of concern that once you put anything out there for country level use, it, you get a whole bunch of demands that you can't meet? So can you just say a little bit more about why we're not already using what is available as country level estimates?
Okay, I want to follow up on that too, because actually we've been exploring this. So like our group, which works with VIMC a lot for economic estimates, has explored using these ROI estimates and cost of illness with countries. So we work with Peking University and the Chinese CDC to talk about the scale up and rollout of PCV and what that would mean, and to do projections and what the ROI would be in that setting. And they use that internally. Similarly, we were approached by the Ministry of Health and PUCE in Ecuador to do the same thing for PCV, to show what the ROI has been, because they were considering cutting funding for it. And it actually informed them to keep funding, and they asked us to do it for all of their vaccines, showing like what the ROI and the economic benefits were for the startup period, and then how they went on later on. So I think there is demand for this, and I think that countries don't necessarily, like, they're not used to thinking that way in a lot of instances, to present things in ROI like at the local level, or they may not have the specific kind of disease burden data for the specific question that they're having. So that might be one thing to like help communicate how these could be used at the country level, but we've experienced a lot of demand for this. So I think that this is, something that countries are asking for and they want.
This Emmanuel from.
Okay, I can start answering some of those questions and then pass it on to you guys. So in terms of the availability of country level data, so part of the issue as to why the Gavi specific forecasts and debts averted are not online is because the Gavi forecast is actually a sensitive information because it has assumptions around introductions, which are not public. So, you know, if a country we have to assume some level of introduction and the country may or may not be aware of that assumption. So, and these are done over 10 years. So there's some assumptions that are embedded in there that are market sensitive and things like that. So that's why we can't make the Gavi forecast available. But we do, the VIMC data is actually available online for each country year for all the vaccines. The forecasts underlying that are forecasts that are similar to how Gavi thinks, but for introductions, we've assumed things like, okay, all countries introduce the vaccine in X date. So that data is actually available, and it's perhaps a visibility question. And I think it's work that the VIMC may have to do in order to advertise that more and to make sure that it's getting usage at the country level. And so that's something that we should definitely work on. Anybody else want to add to that?
One thing is that it's definitely a bandwidth issue. It's like the modelers cannot be doing it by themselves at the country level. As one use case example, and also answering JP's earlier question as well, like one test case is basically engaging with Sudan as well. So this is the ULA was involved. We engaged with Sudan as well, like on a very specific, like kind of the test case that you said, like what is the impact of the vaccines being delivered now and potentially transitioning of Gavi support from Sudan. This is basically ULA was involved and SARA was involved, and the UNICEF MENA team was involved, UNICEF country office was involved, the Ministry of Health in Sudan was one of the EPA program, and all of them are involved in order to, it takes a lot of discussions and ongoing discussions over a number of, like almost more than a year, and in between all of this, the scenario was actually Sudan was transitioning out of Gavi support because 3 years that GDP was above the Gavi threshold. But while doing this project, actually because of the political turmoil, actually GDP went down below the Gavi threshold. So actually they didn't transition. So, but the analysis was conducted and basically looking at the time the Gavi transition was basically over a period of 5 years, like 20% reduction and trying to mobilize the support for Sudan government. So the case was presented, but it didn't actually happen because Sudan is still under Gavi support as well. Now it's an 8-year transition support. It's possible, but you need a lot of stakeholders in order to do it. And that level of capacity is not available. You can provide numerical analysis, but this needs a lot of engagement with the in-country folks and also the need for the Ministry of Health folks to be involved in this process because they are the ones who actually define those vaccinations strategies and scenarios. Yeah, thank you.
Okay, thank you. Just want to contribute to the point 3 about what you are doing. I think I spoke to Raymond earlier about the fact that when COVID struck, Ghana, and of course, I'm sure with respect to almost all other African countries, was not looking inward, but rather was looking for external support. And for how long can you wait until you get external support from all the donor partners? I remember that they had to go into the contingency fund. Fast forward, then we decided to look at what's called Public Health Emergency Fund. And the fund is such that we are not looking at getting funding from outside. There's something called the COVID-19 Health Levy that was introduced during the pandemic high time area. But then the point is that now there's no COVID, as all of us are aware of, that is no longer a pandemic. And so the argument we make into the Ministry of Finance and then the Ministry of Health and Ghana Health Service is that we can make projections as to how much we can get from the COVID-19 health levy, which is a 1% charge on VAT for every good or service procured, instead of abandoning the COVID-19 health levy. Because once WHO declared that COVID is no longer a pandemic. The citizens began to agitate, then why are you charging COVID-19 health levy? And then when the president came up to say there's no COVID, then it even became more intense. And so we've done some projections to tell the Ministry of Finance and Ghana Health Service and the Ministry of Health that if you decide to continue to charge the levy, don't call it COVID-19 health levy, because there's no COVID. Call it a public health emergency levy. And that will go to what Raymond said, looking at pandemic preparedness and response. And that those projections has been made. The good thing is that it wasn't just us doing it, but it involved the Ministry of Finance, you involved the Ministry of Health, you involved academia, you involved WHO and all interested actors. And indeed, it is something that I think if all countries are to adopt it, it's going to help. Because if you look at the pandemic fund, one key criteria I'm sure has to be that you have to show as a country that you've mobilized some resources. So I thought I should share this for all of us to see what model we can also adopt. Thank you.
From the Brazilian Ministry of Health perspective, our capacity needs is to work with dynamic models, especially for vector-borne disease, such as malaria and especially dengue, that is still two severe problems locally.
Thanks. So I just want to add to Sarah Palace's suggestion, and also thank you, Katja, for talking about Sudan. So that's the thing. It does take more than just printing out the numbers and putting them in a nice graph, because first of all, it's not interesting. You just see some numbers and you're like, what do they mean? You know, where do they come from, right? It actually does take some explanation. And I mean, I'm sure you'll agree with me, if you read a measles cost effectiveness study without any epidemiology, without any case fatality rates or any, you know, incidents and where it was collected, it becomes really dull. It's just some numbers in the table, right? And I just don't think anybody would trust that and use it like you. And also I've worked, you know, a lot on all this cost effectiveness. It really does take, as Katja said, somebody in the country who are involved to make it reliable for decision makers. If it's just somebody sitting in Geneva or New York or something, I mean, it's not helpful. And that means it does take collaboration and time and capacity building and all this stuff that we are trying to do. Yeah, it does take that. I don't think Gavi can just print out some things and put it online. It's not going to be used.
Just final, and then we go back to the panel.
On that note, if we can reflect a little bit on these cost-benefit ratios that you had put up, there was 1 to 35, I think, in one of the studies. The Gavi one, I didn't quite see what the ROI was from the slide. And then there was 19 from the 90-plus countries that you were talking about. This has come up in our country context. We just recently did an investment case analysis in Bangladesh, and we get, 14 to 16. And then the Bangladesh government is like, well, but the Gavi study's average is 19, and then there's 35. So how do we position that without a lot of technical details on the assumptions, because it's supposed to go to members of parliament, right? So that they make the investment. So a little bit more on how we can really put that in terms for policymakers. Thank you.
Yeah, I was just reflecting on number one, how can we use evidence in a more meaningful way? The ICANN project, Kelsey's here and a few others who were engaged in that project, really worked hard with country teams. I don't know if Van was engaged in that as well, but to kind of start studies from the perspective of what's really needed at the country level, what kind of a study, and then work all the way through to the end. You've got results, now let's disseminate it. Let's find the pathway for using it more and more. And I would say it wasn't an easy slam dunk to be able to do that. It took a lot of time. It took a lot of energy. But the experiences were varied. So in some cases, if it came at the right moment, it could be used for a policy decision. But to inform programming or changing the way an immunization program would deliver services, that was much more difficult to integrate into decision making. So there's no one size fits all in this respect. I think if we want to have more meaningful engagement and use of results, it takes a lot of kind of dialogue and face time to be able to do that.
Thank you. So back to the panel for their panel reflections.
Just to respond first to Runa's reflection, I completely agree that just presenting the result itself and try to communicate in one way is not a best way to go. And also you need to understand stakeholders' perspective and the needs, because decision maker especially, they're considering many different type of evidence. So you need to understand the broader evidence ecosystem to see, what they're deliberating and what specific type of the questions, because their inquiry start with the questions, and also the decision makers' involvement in the creating, the generating the evidence is the key. Just to yes, and then I want to also react to the ROI, your observation about the ROI. I think is not only I think the communication should not be only taking the face value, the end product outcomes of the ROI estimates, and just try to compare against interventions, compare against different studies, but also communication should really lies in explaining what is driving the difference across the results, like methodology, inputs, and baseline assumptions. That's the key elements for decision makers to understand as well, just beyond the face value of the number itself, right? And maybe like what IBRAC, the committee that I mentioned before, maybe they're endorsing the approach recommending the approach called multi-model comparison approach. So in case this has been applied to mostly the mathematical modelings to help decision maker understand the differences across the model. Maybe similar approach could be also adapted into the other type of evidence, including the benefit cost analysis, to understand different parameters and assumptions, and then this is also aligned with what I mentioned about this co-creation process. Even in the process of interpreting and applying this result into the policies, researchers and decision makers need to collaborate and really walk this journey hand in hand. Thanks.
Yeah, I can comment on the Gavi ROI question. So we don't have a Gavi ROI. There's an immunization generally ROI number, which is the 19-to-1 or with the cost of illness approach, and 54-to-1 if you're doing a VSL approach. So we've mostly used that for advocacy, and part of the reason for not doing a Gavi ROI, specific Gavi ROI, is to not confuse the message. The idea behind putting out this ROI message is really to tell people that immunization is important. So putting out yet another ROI number from our perspective felt like it would be too confusing for stakeholders. And the general message is really just to be saying immunization is important, and it's a big number. So that's essentially what the use case has been on our end.
Would you like to comment on the question from Brazil on dynamic models?
Yeah, sure. Yes, definitely. Please reach out to us with respect to the, and this is the kind of thing we are looking for, like stakeholders to reach out, and then also the capacity to engage at the country level. But what we can provide is on modeling front, we can provide those models, but we'll also work together in order to generate those estimates as well. And specifically in the context of dengue, there's a working group, which is actually helping out WHO with the SAGE recommendations recently as well. So that is another group that you should definitely reach out to as well. And then in general, like the working groups, this is the idea of the working groups in the sense it's not the working group in itself will generate. It's not only VIMC folks, it's going to be a kind of a collaboration and partnership. And so in working together, we'll be able to generate the evidence that's needed. Thank you.
You also cover the malaria modeling, not in the IVMC.
Yes, but VIMC, we do have the malaria models which we can directly engage. But for dengue, especially, there's another working group that's currently working with SAGE. Yeah, thank you.
Okay. Just follow up to Emmanuel's comment. I think it's a good example of because that was also in the task force when we did the mapping exercise that was done by WHO and the World Bank, identifying all these response financing. One of the conclusions was definitely there is not enough domestic initiatives and financing to be that is certainly something that we'd like to focus on. So not only from international funding, but also from domestic financing, and it goes back to our early discussions on transitioning countries. And I think for the coming years, this is really something we should not only in immunization financing, but healthcare financing in general, how to come up with better innovative financing within countries, but also talking to ministries of finance. And I think then we go back to the ROIs, because that to me is the language they understand. You come with the cost per dollar, no idea what you're talking about. It's really about this return of investment. And that might, I think the Ghana example is a really good example that you are kind of anticipating and preparing yourself for the next pandemic to come, but also have your act together in terms of, okay, if we need from day zero the financing, we then have our own systems in place. But definitely also organizations like Gavi, Global Fund, SAPI, they also have their kind of financing ready. Well, they also what we saw during the COVID pandemic, they were also taking their role in providing their funds. And so we within the task force are also talking to these global finance organizations to what is each other's role in the next pandemic, to help countries. But definitely the domestic actions are also needed. It's one of the conclusions we had from the landscape analysis. And to come back to your point on identifying these pinpoints through this landscape, and maybe this landscape analysis might be published soon, and maybe in a paper. I'm not sure what the plans are, but this should be available for a wider audience than only the G20 task force.
Great. Thank you so much for the panel. I think we can wrap this session here. Thanks to the panel. Yeah.
We just have a really brief summary activity. I promise it's short. We just wanted to end on a bit of a happy note. So where did the clicker go? Did someone steal the clicker? Oh, it's over there. So just to mention what a pre-Congress it's been. It's been a great meeting, 2 days with 36 presentations across 12 sessions. We've had more than 150 participants over the 2 days coming from more than 42 countries. And we've had participants joining virtually, which we didn't manage to count yet. So what are some of the key takeaways that we've been hearing over the couple of 2 days? So we need to better link up our community of practice with data users, and we need to tailor our research findings to the formats that they need. We heard that our research and support needs to meet the demand of governments and subnational level practitioners as well. Then we heard we might benefit from defining what our key research priorities are, and we need more cost evidence on reaching zero-dose children, on integration, on campaigns. We need more work around budget execution at national and subnational levels. Sometimes we might need to provide countries with approaches to technical assistance to implement those rather than coming up with standardized tools. So this is some of the stuff that we heard. And then we want to hear from you. So please log into Menti, use the code that's on the screen or use the QR code. And then we want to hear from you what you found were the key takeaways from this session. So we'll give you a moment to get on.
So just to add, our plan is to send a more detailed survey later on, but we just want to get your final initial thoughts just through Menti. If you're not on yet, you could just do the menti.com on the screen, at the top of the screen, and use that code. The first question, what are your key takeaways from the Immunization Economics Pre-Congress? So keep it nice.
your response short to like 1 or 2 words, otherwise this doesn't work. You can add more than 1 response. I think it has 3 fields, so just keep on adding.
I enjoy the costing is hard.
Seems like we still find 0 dose important, even though we say it's a buzzword. Integration, important, huh? We'll have to think of better ways to link up our community with the PHC costing community as well.
Hello. Maybe we can move on to the next question. Okay, so next question is, what did you like best about the Immunization Economics Pre-Congress? This might be a type of session, this might be a topic, this might be lunch or coffee. What? But
Or just seeing our colleagues.
Yes, of course, seeing people face to face. Networking is coming up, which shows I think we've all got a lot of Zoom fatigue.
And diversity, which is great because we really aimed for that, like have a lot of different institutions represented. And great people. We're all talking about ourselves here. Music as well. That was not our choice. For that, we can thank the IT team. And the posters were great indeed. So for all poster presenters, you can pick up your poster after this session. You can take it home. You can go grab it in the room. On to the next one, perhaps?
Yeah. So final question, promise. So what are your recommendations for future immunization economics sessions? Again, keeping it nice and short. We'll send a more detailed survey later on where you can give us paragraphs.
So that could be for a future pre-Congress session like this, but it could also be any other kind of virtual convening that we would do, or any kind of new type of convening that you think we should consider, just how we should get together in the future, basically, and any recommendations for that. Yeah, MOH voice is very important. This seems relatively varied, huh? More networking, yeah. Less eating into the breaks, perhaps, with with our sessions. Yeah, apart from networking, nothing really seems to jump out yet, huh? It seems like our recommendations are all different. But we'll read them all in detail, don't worry. More focus on subnational work. Yeah,
Can leave
I
it
think
there.
that's it.
Yeah.
Yeah.
Well, thank you.
That's really all we had. So we wanted to just keep the summary short. We know everyone's tired, and so we didn't want to do a full summary of the 2 days. As Rachel mentioned, we'll still send out a more formal survey as well to really get your thoughts on this session. And I think we can just jump to the last slide. Didn't we have it? Yeah. So I think I can just wrap up by saying thanks to everyone. Thanks to the presenters for great presentations, great discussions, to the panelists as well, to the participants for asking wonderful questions and getting a lot of interesting discussions started. And then just I want to also thank the IT team, the catering, the security, everyone that helped out to make this happen, and IHEA, of course, and then our team, of course, Rachel, Christina, Flavia, for helping us out and organize this session. So thanks, everyone.